All right, everybody. Hello, good afternoon. It is officially afternoon, so we'll go ahead and get started. Thank you so much, everyone, for coming. This is our last Research Roundtable Seminar of the semester, and this is our second semester doing this. So we're very excited. We've been really pleased overall with the turnout, with the participation, and of course with our presenters as well. If you've attended before, you know that we have a survey that we ask you all to fill out. And I know that a lot of times we just get survey fatigue, but if you could please, scan this right now. You can fill it out now or you can fill it out after, but we're looking for feedback both on today's presentation, but also for the semester, just overall, just quick slide between 1 and 5. 1 is low, 5 is high. And then there's a little optional box where if you want to recommend topics for next semester, we're starting the process right now of planning our topics for next semester, or even the next 2 semesters. So thank you so much. I appreciate all of that. I'll start with our land acknowledgement. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education, offerings, partnerships, and community service. So with that, we'll move into our presentations. We're joined by 2 wonderful people today. Our topic for today is AI and digital health. So we'll hear from Dr. Shravan Aras and then also Dr. Onicio Leal Neto. And I think you'll find the presentations to be really interesting and really exciting. So we'll begin with Dr. Aras. Thank you.
All right. Well, good afternoon, everyone, and thank you for coming. I know it's lunchtime, so I'm hungry. Thank you for being here at this point. All right, so today we're going to talk about making sense of senses using AI. I was trying to not use the S word too much, but it kind of came up there. So a recent survey found out that almost 100 million users across the United States have some form of a wearable device that they use. That's about 30% of our population right now using wearable devices. So just a show of hands, how many folks are currently using a wearable device? It could be an Apple Watch, a Fitbit, any of that kind of stuff. All right, that's a decent number of folks out here. And so why wearables, right? And why are we focusing on wearable devices at this stage? I believe the wearable devices do 2 things. They act as a check engine light for your body, and they can also act as a gateway into our community. And so wearable devices give us a rich amount of data. So they give you all your cardiac data, so like your heart rate data and all of those different things. They also give you data modalities like skin temperature. They give you sleep information like duration, efficiency of sleep and all of those different things. And everyone knows they also give you activity data. So you have all of this rich context of data. Well, what do you do with it though? Like in most situations, we all want to collect data, we're not really sure what to do with all of that information once you've collected that. Well, there comes AI, right? So I believe that AI and wearables is a perfect match. And why do I say that, right? So there's a ton of data that's generated from wearable devices. Every 5 minutes, you get heart rate data. You get temperature data every single minute from these devices passively without you having to do anything. Compare that to the traditional self-reported outcomes where you only get measures when somebody visits a clinic or they do a survey. You have all this rich context of data. And what's the one thing that AI loves? Data, right? So you feed it tons of data. AI loves data. It's going to eat up through the whole data. And that's why I believe AI and wearables is a perfect match for each other right there. What can it let us do? It can let us focus on population health outcomes to be able to study what happens in our community using wearables and AI devices. But there's a slight problem. AI has been designed ground up to be a very structured framework, right? It started off with images, you looked at your cats and dogs images and you figured out what they were. And they kind of went through the structured sequence of different layers, like convolution layers, dense layers, and all of those different things to finally give you a prediction on the other side. Well, sadly, that doesn't really work that well for sensors. And why does that happen? So wearable sensors have tons of noise in them. So me just moving and walking right now is creating noise into my wearable device. Me being in different environments is creating noise in my wearable device. Non-uniform sampling rate. So some modalities like heart rate are probably sampled once every minute. You have temperature data sampled every 5 minutes. You have electrodermal activity, which is sampled several times every single minute. So you have all these different variable non-homogeneous sampling rates, which you now need to figure out how to address all of those things together. And anybody who's worked with remote sensing, I'm sure can resonate with this. Tons of missing data. The average compliance right now for wearable remote studies is 55%. I mean, I don't know about you guys, but that seems pretty low to me. We need to do something about it, right? You can push it to almost 70% by building in compliance metrics into your study as well. But I've heard it all. I've heard stuff from the dog chew my Fitbit to it fell into the pool. It broke. I gave it to my friend. It got lost. All of those different things come in. So we have tons of missingness, which we have to deal with no matter what. So this is a classical pipeline. I'm not going to get into too much details with this, but you have your standard imputation, which does create bias. You have your aggregation in there as well, which could cause loss of information. And then you have your autoregressive components, but there's a limitation to how behind in time you can look through with some of those modeling mechanisms. So how can we use AI to perhaps fix some of these different things, right? Highlighting a few things here, AI loves high dimensionality. So the more high dimensional we are, the better for it. So we don't need to reduce dimensions. We either keep them as it is, or we actually bump up the dimensions to a higher dimensionality. I want to focus on attention blocks. So everybody has used LLMs, and the core behind LLMs right now is attention blocks, transformers. The classic paper that says attention is all you need was all about transformers. And these attention blocks can also be used for sensors. Sensors are longitudinal time series, and so are words and sentences. We can draw parallels from NLP and sensor analysis. And so these attention blocks can essentially hold a giant matrix of how a particular sequence relates to a sequence before it, allowing us to model these different sequences of variable lengths. So I'm trying to get to the point of we have some future of using AI with these wearable devices. But there's a ton of limitations. I'm only going to focus on a couple of ones here. It takes a ton of memory. It takes an order of n squared memory, so it's quadratic memory. If you guys are looking at the news right now, the cost of memory is going up and up. That's because we need a ton of memory to run these models. So if you are trying to run a model with variable sequence data for 5 years, well, better have deep pockets. You're going to need a ton of good amount of memory to be able to run some of these different models. I want to go ahead and highlight two different projects that we have done with AI so far. So one of the first projects which we work very closely with College of Medicine and Dr. Erickson and her team is about being able to predict when labor will start. And right now there isn't any tool. So we used physiological data as well as AI to start answering that particular question. So today, about 5% of mothers go into labor on their estimated due date. The rest 95% of mothers do not go into labor during that due date. They go somewhere around that, but we can definitely do better than that. So I want to get off started, like how do you build a model like that? So you have AI at the very top, but you have all of these different things in the bottom, data engineering, cleaning, DevOps, all of those things that people don't actually see that sit under the iceberg of AI that needs to be created as well. So I want to walk you guys through how that pipeline looks like. So we had data coming from a wearable device. We used Aura Ring devices in this particular study that went into our AWS infrastructure, which was cleaned up, and we used a ETL pipeline to then go ahead and attach it to a AI model. And the AI model was then able to create predictions, which were translated to a clinical outcomes user interface, which clinicians can actually use and start making inference based on that. This is a snapshot of how one of our cleaning pipelines look like. So we have temperature data that's coming in every single minute. We go ahead and aggregate that, but we want to remove motion artifacts. So we go ahead and create a mask of when they're moving and when they're non-stationary to be able to remove those different segments and let our AI model know that those particular segments are probably unclean. Maybe don't put too much weight on those particular segments. Being able to mask them with movement That's kind of the multimodality of these different things. And once it's clean, we can go ahead and add that to the AI model. This is a snapshot of how our AI model looks like. It's an AELSTM, so autoencoder long short-term memory model. It's able to analyze different sequences, and it uses an autoencoder technique that takes raw sensor data and converts it into a latent space before feeding it into an LSTM network. At the end of the day, this is what we have. So we provide our clinicians with a window of when the labor will start. We give about a 7.6 day window with a 79% accuracy, so the clinicians can know when labor will start for the mothers in their practice. We wanted to also study the effects of hallucination on this, and one of the methods that we use quite frequently is when we have an AI model giving output, we go back and try to see what portions of the input were actually related to it. So we do three different things. We do something called as flatlining, where we replace random bits and chunks of the input data with just zeros or the means of that particular data, and we see how does it affect the output. If it doesn't have any difference in the output, I'm very worried about that, by the way. It means the AI has learned something which is not what it wanted to learn. So I don't know if you guys remember when COVID happened, everybody was releasing these models that could look at lung x-rays and tell you if you had COVID or not. And then after a couple of iterations, it came out that they were actually looking at the thing at the bottom right, where you had your date of birth and a couple of other things, and they were able to just train based on the probability of somebody being a particular age and having the possibility of COVID. So it's really important to know what your models are looking at, and there are some fuzzing techniques that can be used to make sure your models are not hallucinating. If you guys would like to learn more about it, feel free to go take the paper. Shameless plug, we're also enrolling into the study to ABRC and Flynn. So if you know anybody who's pregnant, please have them sign the score. We are supposed to hit 300 mothers by the end of 2 more years, both high risk and non-native pregnancies as well. Moving on to the second project, which I want to talk about. So shifting from just wearables and AI to wearables, clinical decision support systems, and AI. So as you guys might have noticed, right now, the average wait time for a PCP appointment is about 30 days in Arizona. So you pick up the phone, and if you don't have a good relationship with your PCP, you ask them for an appointment, and it's going to take you about 2 to 3 weeks to get and see a doctor. I think that's too long. So what students have done, so Senior and Firoz who are in the audience over here, they've built out this clinic kiosk AI system. And essentially, it's a kiosk platform that integrates wearable devices, vital sign measurement devices, and connects to a clinical decision support AI-based system, which I'll talk a little bit about in the next few slides. But that's able to simulate the medical diagnostic flow that you would go through when you're doing a differential diagnosis. So we worked very closely with College of Medicine to be able to do this as part of our collaborative efforts. This is a grand vision of how that would look like. So we have three different components which the students are working on right now. We have the medical knowledge graph. We have the GNN RAG, so your graph neural network and retrieval augmented generation. And we have the foundation LLM layer on top of it. So the medical knowledge graph has symptoms, diseases, and all of those different things that connect, which act like the ground truth. So it's not like asking ChatGPT, hey, I have a cold, what do I do with it? We're actually training this medical knowledge graph in the back to have all these different associations in it. The graph neural networks allow us to understand what weights to put on all these different associations, and then the foundation LLM models sit on top of it and orchestrate all of these different conversations using all the two components I just mentioned. This is a snapshot of a decision-making flowchart that we use. AI has this within it, and it can be adapted for any other decision support flowchart that we would like for it. This was made for an ER scenario, so the AI can go and navigate this and then connect to its knowledge base in the back. Here is a simple example of how our knowledge graph looks like and all the different entities it covers. So we cover everything from vital signs to symptoms, to different phenotypes, as well as different demographic information and past history as well. So every single time the AI is interacting with you through our system, it's going through this knowledge graph that connects to all these different elements. It's looking at your vital signs, it's looking at the decision flow diagram to figure out how can I ask the next question, so I can narrow down my sample space so I can figure out what the diagnostic needs to be. Here's an example of how database looks like right now. That's a live example of all the different nodes we have in the knowledge graph at this point. And I know Osini and Firoz are working really hard to keep on building on top of it so that we can support the top 10 diseases that are most common right now when you go into telehealth. And this is a demo of them using the system. Right now, it's located at the Digital Health Technology and Sensors Growth Facility on the second floor of the Health Science Library.
Your kiosk.
Oh.
What brings you?
I'm gonna skip that because I didn't know there was audio on that. All right, but that's the verbal interaction that you can do with it as well. And they have a small video recording of them going and talking to it, taking their vital signs, connecting an Empatica wearable device. So it's a full ecosystem, and you could put this kiosk maybe in another year or two in every corner or every remote location where you want to offer these kind of services. I want to mention that we have the AI Summer School coming up, which Onicio is organizing starting in June 8th. If you guys haven't registered, please go ahead and do that. I'll be introducing something called as a sensor AI playground, where you'll be able to drag and drop and pick between different sensor modalities and then connect different AI algorithms to it so you can get hands-on training and practice on how to use AI algorithms on sensor data. And we also have our code facility, Digital Health Technology and Sensor Code. If anyone's interested in coming and checking out, learning about sensors and AI, please come visit us. You can also see a demo of the kiosk over there, and a ton of other things that you can get to use there as well. And with that, thank you so much.
Hello, everybody. I'm Onicio Leal Neto, and our conversation is going to be about AI in public health, from technology push to public health pull. I'm going to start saying that we should acknowledge the utilization of AI and machine learning into the public health space for a long, long time, right? We can see those are publications on PubMed showing that we see activity pre-ChatGPT release for sure. And it turns out when we had the ChatGPT release by November 2022, things changed dramatically. And this corner right here is devoted to the surges of generative AI tools. And this is what I want to focus today's talk, the generative AI role in the public health teaching, training, and research. For those that never realized, those are the top 10 generative AI labs that are perform better in all of benchmarks right now. So maybe you know about Anthropic or Meta or OpenAI or in Google. Maybe you have no idea that Baidu, Alibaba, and DeepSeek, 3 Chinese models, are within the top 10 makers of those generative AI models. Also, we have the model built by Elon Musk right here. So despite being a very controversial person, they are doing a good job in building technology or enabling different technologies for us, right? And if you notice, all of that is mapped of who has the tools, but public health is not on it. And that's the point. So sometimes I heard arguments that, well, I just want to use AI in my research or my work in public health when we have a public health agency developing something like that. But if we wait until there, maybe we're just waiting forever, right? So while we are not getting there yet, we can see a lot of immediate applications of generative AI into the routine of public health practice and research. But I'm not talking about the very obvious use cases, right? I'm sure that some of you that experienced already generative AI, you guys maybe did text generation or ideas generation or proofreading about some manuscript that you are just writing or doing literature summaries, right? So those are the overrated, the obvious utilizations of those kinds of tools. Instead, I want to bring your attention to the non-obvious utilizations that people didn't realize that they can do using generative AI. For the most simple ones, like contact extraction. So imagine that you have records from handwritten notes and you want to transform that in a structured data set. So generative AI can help a lot with that. Or working with multimodal data analysis, so combining tabular data with image data with audio data. Generative AI also can help you with that. And I want to give focus in two different applications that I'm gonna bring some examples: prototyping with generative AI and synthetic data generation. So in this first example, without generative AI, it used to be possible to do prototyping stuff, right? And when I mean prototype, I'm referring to software artifacts. But that would require you some kind of coding knowledge to build something, right? Generative AI just shortens this path and provides you a way to run prototypes without knowing or without developing fluency in coding, like no code and low code approach. So this is a project a study that I'm developing in Brazil. Basically, this study is about repurposing epidemic models for organizational learning environments. We are treating how learning happens in an institution as if learning would be a epidemic or a pathogen. And we are trying to measure how fast this learning happens within those organizations. So the challenges that I have for that was building a dashboard that my local team in Brazil could see the data analysis happening in real time and bringing different insights for that stage of research. And since we are working with social network analysis, this is not a super obvious capability that basic research staff would have for that kind of setting. Also, in that project, we are just developing we are just applying a machine learning model, random forest, to identify which are the variables that matter most for that kind of phenomena that we are seeing in terms of learning spreading. If I would build a prototype from scratch without generative AI, that would cost a lot for me, that would take a lot of time. And if I hit my capabilities of coding that, I would need to hire someone and I would need to pay a lot of money for this person. And in the end, I will still have some constraints about matching my expectation with the deliverable from the software engineer. Instead, I just started using Claude to build the software for me. And those are the lines of code that Claude generated for this dashboard that I'm going to show you in a minute. But just to highlight that Claude was able to produce a super elegant, commented, and optimized code for developing the dashboard that I needed with 1,400 lines of code in Python, delivered in a self-contained HTML. So, which means that I just need to host this HTML file in some server, and then my team in Brazil could just update or upload the files, the CSV files in the application. So this is how the application looks like. I'm just drag and drop the CSV files there and just hitting the button on launch dashboard. This will load and this will give my team and me a capability to visualize all of my research data that I'm acquiring in real time with the most sophisticated capabilities for working with graph networks like that. And again, if maybe I could be able to do something like that without generative AI, but then that would take me maybe 4 or 5 months to implement instead of 2 weeks. The second example that I want to talk about is on the synthetic data generation side. So this is another project that is funded by the Arizona Department of Health Services. Basically, we are trying to prove a association between social contact patterns and the multi-drug resistant organism profile within nursing homes. So we are using these proximity sensors and distributing among patients and healthcare workers. So every time the two or more study participants are facing each other, this sensor extract power packets, and then we can measure how far they were from each other and for how long. And then we will combine this with their electronic health records in terms of their profile for multi-drug resistant organisms and see how much the social network structure played a role for acquiring new MDROs in this sense. And we expect to have something like that in the end, right? So a social contact data set with the advantage that I'm doing that in high frequency. So the resolution of a data set like that is super high. And when we have a high resolution data set and we want to extrapolate this thing, generative AI architecture does a very nice work with that. That's why we are in this project, we are just getting this real data, feeding the models to reconstruct the synthetic data with the advantage to preserving the identities of those participants so we can share this kind of realistic data set without harming the privacy of our study participants and also without having any problem with IRBs in this sense. And I think it's very clear that AI is now the largest force shaping information. But there is a problem, right? The problem is AI was not built by public health. So how can we balance this conversation, right? So the current paradigm is a very technology-first approach. Basically, technologies, people from computer science, from data science, nothing personal, Shravan. But people without a public health background, they are getting the domains from artificial intelligence, machine learning, and try to push them into public health problems and see public health as the nails, right? So we have the hammer, let's find the public health nails and try to solve that kind of situation. And things have been working like that for a long time. And this brings a lot of problems. It brings a context blindness. When they are doing like that, they are just ignoring the social determinants of health, the health equity. They maybe are increasing the health disparities. They are not considering the community dynamics that shape health outcomes. So a lot of problems that this model can perpetuate. Also, sometimes we face the wrong messenger. So imagine an instructor with no practice in public health, teaching public health students on how to do things in public health, just because they are using AI. So it's a very critical situation that we need to pay attention with that. And it goes as well for the critical thinking gap. How come a person that is trying to build or to deploy tools that utilize AI and machine learning without any kind of experience will fill the gap that our students have in understanding how things work in the real world setting. And finally, this approach can just transform artificial intelligence tools as inequality machines, which I think we don't need anything else to increase even more the inequality, the health inequalities that we see nowadays. So instead of this current paradigm, we are trying to propose a new paradigm, which is a public health-centered approach. So instead of starting by the AI and machine learning domains, we are starting by the public health study pack, right? The very basic domains that we do in public health all the time, like determinants of health or epidemiology or health behavior and others. And then reach the tools, AI machine learning, as instruments, not as destinations. And when we do that, we could, for example, promote the workforce relief. So imagining enhancing and enabling public health workers with a new set of tools that can solve actual problems that they are facing in their routine instead of just increasing the burden that they face in their daily lives. Or expanding our research capacities in public health. So imagine that now you can work not only with tabular data, but also with other kinds of data formats as well in your public health data pipeline for research. And ultimately, building these capabilities of in students to be not only AI users, but to be AI critical thinkers. Because if we want to be sitting in the top 10 generative AI labs, we need to bring to the table our capabilities, our background in public health, and try to be part of this conversation and maybe generating some kind of difference for the models that they are releasing. Because you would be surprised if you see how much biased those models are when the topic is population health. And just to finish my talk, this is something that I get all the time when I'm talking about artificial intelligence in public health and the environmental impact, right? To facilitate your life, I just put together a website that will tell you the hidden cost of your digital life. And that's no problem in being concerned about the environmental impact of AI. But do not forget that when you are listening to a podcast or when you are watching your favorite Netflix TV show, you are harming the impact more than just using generative AI for doing some prompt. Because the conversation is not about AI, the conversation is about data centers. And if we are talking about data centers, we need to consider all of the technologies or all of the data that make this traffic and that will impact the environment in these purposes. So take a look on this website if you are interested in this conversation, because maybe next time that we make this question about how about the environmental impact of AI, we can change for how about the environmental impact of data centers, and then we start a conversation in a more genuine and coherent way. So my claim here is not more AI in public health, instead more public health in AI. And if you really want to expand this conversation, besides these 15 minutes, I'm inviting you all to register for our public health and AI summer school. We still have only 10 seats remaining. So if you are not registered yet, secure your spot today. And Shravan will be there. So if I were you, I would just to see Shravan talking about the sensors and technologies and wearables like that. And that's it. Any questions, just send me an email. I'll be happy to take questions. Thank you.
Thank you. At this time, excuse me, I invite both of you actually to join us up front, and we'll have a Q&A session for everyone online. If you have a question, please type it into the chat and I will field it as well. While they're getting settled, again, here's that QR code if you haven't scanned it yet to scan to fill out our survey for today's seminar. And if you would like to suggest any topics for next semester, you can do it at this time. Any questions?
So years ago, I was at an AI conference in Orange County where we talked about research that was being done by a French researcher in Boston in Mass General. And he talked about how AI was being utilized to look at all of the data that we don't pay attention to in the ICU. And it was able to predict the death of patients that were anonymized before the AI was trained within minutes of the actual death occurring. In fact, was able to predict within 15 minutes when things were going downhill that maybe we could try to intercede if we had the right sensory tools available to our nursing staff to engage our medical staff when that was going down that path. And I'm struck by that from our own use of sensors. And I'm wondering if you know of or have any thoughts on how we can engage AI with our sensors for our rings or our watches or whatever, to start to really pay closer attention to our data in those quiet moments that you were talking about.
Absolutely, that's a great question. I think one of the examples that comes to my mind is early infection detection. So that's something that we are actively looking at right now, is looking at how your skin temperature changes. We're looking at it in the space of pregnancy and maternal health. I can see that application even outside my space as well. If you're having an infection, you're going to start seeing your heart rate rise as well. And it's going to start going beyond your baseline. You're also going to start seeing fluctuations from the skin temperature as well. Just using those two different modalities, you can definitely create a early warning system that goes and starts with infection detection. If you're able to start evaluating the infection detection, you can also start looking at an alarmist scale, the zip code wise as well. So that's one of the things that we are actually looking at. And a clinical setting, we're also looking at postpartum hemorrhage, and we're looking at sensors that are trying to predict in a small little scale if we're going to have nutrient and funny or not, I'm spacing out on the words right now. But the goal there is to make sure that the bleeding can stop. And we're trying to look at these different contraction patterns when the mother is in labor to be able to get those. So some of those tools are kind of already in play. I think the biggest challenge, which I don't have an answer to right now, is in a clinical setting, it can't impede the procedure that's being done, obviously, and that creates a bunch of different challenges for testing collected data. And in a household setting, we don't know what the next steps are going to be. So let's say like you pop up a flash message on the screen saying, hey, you're probably going to get infection, you're feeling sick. Now, is the medical professional team going to take that? What's the next step? What's the next handle? So those are open challenges which we haven't figured out yet after researching mechanisms happen.
If I may add another challenge, by working with wearables, we are just bringing a new paradigm for data management to people that use work with low frequency data, right? So wearables collect data in super high frequency. So you need to deal with this, think about different sample rates instead of having a service that will collect data once a week or once a month. Now you are getting data pretty much every minute or every second. And there is a gap of training to deal with this kind of frequency of data, right? At least in public health field in a more general way. At the moment that we tackle this challenge about teaching students or professionals on how to deal with the paradigm of high frequency data, we can start seeing people enabling these kinds of data sets from wearables, for example, towards populational health purposes. Recently, I think it was last week, was published a paper on Nature saying that all of us data now has available the Fitbit data as well. So we are just moving the paradigm of having those surveys that were collected, I don't know, once a week or once a month. Now we are getting just Fitbit data that have your activity data points every single minute, and how our students will be analyzing this kind of data.
I have two questions from online. The first one is, how can we build trust with communities when using passive data collection methods like sensors or digital tracking?
This is a repeat of a question from 2 weeks back. Okay, I'm trying to think what I said there, but probably won't say the same thing again. Being transparent, and not just transparency as researchers, but also being transparent from the different OEM manufacturers. So every OEM manufacturer, whether it's Fitbit, Garmin, Apple, will explicitly have terms and conditions laid out there. Our institutional review board may or may not be always aware of this. So as researchers, it's our responsibility to let them know that, hey, when you go and say a participant needs to have Apple Watch or Fitbit, you're retrospectively getting their data from the whole period. Except for Garmin, as far as I know right now, no other device manufacturer only gives you a snapshot of the data. So being transparent to your participants, saying that, yeah, we're getting all your data, but we're not going to really use it. We're only going to start using it after you have enrolled. And these are the modalities you're going to use it, because it's very easy when you see the data, like, oh, I don't really want to study heart rate, but I want to go and do that because now I have the data for it. Or I didn't want to look at sleep, I was only going to look at steps. Now I have the data for it. So building that level of trust with transparency, but also letting them know that some stuff is beyond our control. Because at the end of the day, the data stewards are the OEM device manufacturers, original equipment manufacturers like Google and Apple that have some say in this ecosystem as well.
The next question says, I'm wondering how we can get sensors to rural populations as women/families must travel such long distances for OBGYN care.
That's amazing. That's a brilliant question. And I think one of our pitches for the kiosk is exactly that, right? So if you have rural healthcare, so we were talking to the chief of medicine down at Cells, and we learned a lot. This was part of an ICOR innovative core program that the MAJ sponsors. We get to interview different stakeholders to understand what the needs in the community are, but also the needs of other people are going to be. And one of the biggest things there was that, we don't have cell service. Literally, like, you have to like walk to the nearest bashas, I think that's there right now, flies, to get any cells range or use their Wi-Fi and sit there. So what we are proposing with solutions like a fully self-contained kiosk is that instead of having cell service propagate to the whole community, you have cell service on one single thing. You connect that to satellites, to LoRa, any amount of technology that will go into it. And that can become your point of care for a rural setting where everyone comes to. I know that's not the ideal one. Ideally, I would love to say that everybody somehow gets cell service everywhere, but in the meantime, while the rural health bills go out and the non-metro bill that is going out to have cell service and internet across all the different rural communities, we can have an internet solution where they can go to a point of care. They can get the wearable device and they can go back there maybe every few days to sync their device with the kiosk, but also do all the vital sign measurements for them. So that's one of our biggest motivation to create that self-contained unit, because then we can create control the connectivity of it as well.
Thank you.
Very interesting talk. I welcome either you guys to comment on this. So in your talk, or you mentioned the kiosk, you mentioned like patient demographics and how that we take it into account. You can't really deny that, like, different conditions, genetic conditions, heart attack symptoms, list goes on and on, can present differently in men and women, ethnicities, etc. We also know that like a lot of health research has not incorporated equally a lot of communities. They've been like based off of like European for the most part, and like luckily since like the 1990s that shifted into more informed. But when we have that data, how are we like know that AI can like actually synthesize that and make sure that we're not, people are human too, like can be flaws, but like how are we not like perpetuating, like Onicio was saying, like health disparities in that if we're not considering the people in the data that we have. That makes sense.
From my point of view, unfortunately, because AI is trained on information that humans have created, we do have a weakness of bias. We need to agree on this. Once we have a substance of that, then we can start figuring out how can we tackle that. Technically speaking, there are methods of looking at different biases, but being aware of that bias being there, and then trying to test in those particular demographics is very, very important. And so with one of our aims, actually one of our APRC aims is also to go and test how these tools are going to work in underserved populations. Because like you said, it's hard to get data on those populations. They have a very small amount of data available, and all the studies that have been done in the past, all your statistical modeling and your risk scoring that's been done is done on a generalized population, which does not. So that's the dream of personalized medicine and personalized healthcare and digital training and all those fancy words. We're going to try somehow figuring out if we can personalize the care to the particular individual. Right now, practically what we are doing is we're just going ahead and testing our solutions in these different demographic cohorts and different demographic segments to the extent that we can. But in the clinical setting, there's this notion of a AI card. The card essentially tells you on what demographics your algorithms are doing on, what the caveats of those algorithms are, and that gives you transparency about when you interpret the output that comes from it. It can't take the responsibility. The output comes from it. What exactly do you need to look at? So if it's not trained on a particular subset, you might think that that's for the fields.
8 years ago, I was deploying a project in rural villages in Malawi where we were doing facial coding application to identify stress level in kids between 2 and 5 years old. And this facial coding was, so the health surveillance assistant used to have a tablet and make a short video with the face of the kid, and then that model would estimate the stress level of that kid. The caveat was the model has a very nice and high performance metric, but model was trained with kids in the suburbs of New Jersey, completely different from rural villages in Malawi. And we saw the model like generating bias in real time. And then we decided to shut out that part of the project, not using at all the visual coding component, because this risk. So this is an actual risk. This happens. And sometimes some kind of research belief don't allow you to switch down a product, right? Because you have dollars, you have the funders of that. But it's very tricky, but it's very important to keep attention about this kind of thing, because I could simply say that the model was performing well enough, right? Or the problem was with my the participants instead of how the model was by itself or that kind of thing.
Yeah.
Just going to contribute a little bit to this, and we have had these discussions offline, but you have used the metaphor of the hammer, no? Sometimes we have this tool and then we think everything is a nail, and sometimes we need a screwdriver. So we have the problem of the productive function of memory or the productive function of computation. Then can you comment in methods, for example, how we can actually use AI and other methods to reduce that dimensionality or to reduce the complexity of the time, or how really can identify some elements that can we try to make this more linear? Because we go to the other problem, the connectivity, then we need to be able to run that in low power devices, and we don't have the connectivity, we cannot access the data center, we cannot run the models in the cloud when we are in this. Just to points and
Jose, you asked me difficult questions.
yes, I know, but
Let's
engage in the discussion.
So I think I'm gonna go far-fetched, 10 years from today, and I do feel like quantum AI and quantum NLP at some point will be the saving grace for all of us, right? Quantum computing is coming up, and that's the end goal of the promise. Short term, though, there are several techniques that have come out recently, so quantization. So if you guys, so computers look at numbers and integers in 8 bits, so 8 ones and zeros, or 16 ones and zeros, 32 ones and zeros. And as you go with higher precision, you get better output. But you can also quantize it to a smaller value, so like 4 bits, maybe 2 bits. I've not seen 2-bit models. So 4 bits or 6 bits or 8 bits, right? You can reduce the precision. But the question now is that do we need these giant foundation models, or can we distill that knowledge to specific use cases? So for example, if I'm looking at infection, maybe I just need a small model that's distilled. It's kind of what DeepSeek did, right? They took all these big foundation models and distilled their one model from it, which surprisingly get better results. Can we make these tiny 8 billion parameter models that can run on my phone? And hardware is getting really good with the tensor processing units inside the hardware now. A lot of companies are pushing forward too, where we can start running these onto it. I think Google recently came out with a very sparse representation of the attention heads and attention layers, so that you're not really taking up all of n square space, but you have sparse representations. And I feel like that's kind of going back to computer science 20 years back, because we've always had this problem where we've had a problem of too much information and algorithms which are not linear, and then we've done the divide and conquer loop, and then we've somehow found a method, even like graph theory and all of those different things, to come up with an answer for that. So definitely distilling it to smaller models, quantizing the models, and really asking the question, do I need a model that does everything, or can my model do one specific thing, run on my phone, and that's what my outcome is going.
And just to add a temporary solution, the human in the loop conversation also plays a role in this kind of chart, right? And I said it's temporary because I don't know how things will evolve. So I think it's gonna be possible for a human continuing the loop maybe in a few years. But so far, this is what we could do to avoid this kind of bias or to avoid overfeeding of the models or things like that. That could ultimately harm the person that we will have this kind of coverage at that time.
Onicio, you mentioned that the popular AI models is like it's a lot of bias when it comes to public health problems. Go a little bit more into that.
Yeah. Going to the technology-centric approach, in which moment they consider or they balance or they weighted the social health determinants, for example, when building that model or when building the mechanism to produce that output specifically when someone was asking a public health question. So the very basic stuff, we are not discussing like the most sophisticated approach or heuristics for that one specific. But the makers of the model are aware about the study type of public health, which includes foundational aspects of it. I don't think so. And if you look, OpenAI, Anthropic, Google, Meta, other big tech companies, once in a while, they open positions with the profile of public health and AI. They are paying like $400,000 per year. Clearly, they don't have these capabilities internally, and clearly they can't find people in the market, the job market. So I think this sends us the message that we need to train the next generation of public health professionals to occupy those positions and to make the difference to avoid or reducing the bias that those bodies will be perpetuating if they don't do anything about that.
Any last questions? All right, thank you so much. Thank you again, everyone, for coming. And I look forward to hearing your thoughts for next semester.